Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anis Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the care of patients with gallbladder and bile duct cancer with Dr. Justin Persico. Dr. Persico is an assistant professor of medicine in medical oncology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, Justin, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Well, I'm a Connecticut native, and I traveled the country during my training, but landed back here at Yale. Luckily, where my family is, I have my wife's from Connecticut. I have two children here as well, and my interest in oncology really developed out of what I would call the doctor-patient relationship and the intimate relationship that we develop. And I think in oncology we get to develop very intense relationships with patients and being able to help them through cancer, its treatment, its diagnosis, its survivorship has been my privilege.
Yeah, so we're going to be talking about gallbladder and bile duct cancer. Many people, including myself, were not aware that it is Gallbladder and Bile Duct Cancer Awareness Month, which might be a good reason for us to have more awareness. But it is not one of those common cancers that we think about. We all know October as Breast Cancer Awareness Month. Many people may know November as being Prostate Cancer Awareness Month. But we don't hear as much about gallbladder and bile duct cancer. So can you paint a picture for us of how common these are? What are the risk factors? Who gets it? How bad is it? And so on?
Well, as a gastrointestinal oncologist, this is an area where I see more patients, but it's actually a very rare cancer. It's the number 13 cancer in terms of incidence annually. Typically, about 30,000 cases annually per year. That, as compared to breast cancer, which has 300,000 cases per year, it is also unfortunately a deadly cancer with almost 30,000 deaths per year as well. But compared to something like lung cancer, which has 125,000 deaths per year, it's still dwarfed by those other more common cancers.
And so, when we think about gallbladder and bile duct cancers, what causes it? Do we know about risk factors? Are there genetic markers that we should know about? Environmental factors, other things?
I think the first thing to clarify with bile duct cancer is that it actually is a spectrum of cancers. So the term that we use for this type of cancer is cholangiocarcinoma, and these can either occur in the gallbladder or bile ducts as most people understand the anatomy, but also the small bile ducts within the liver. So it is one type of primary liver cancer as well. And the risk factors for those different sites of cancer are slightly different. The most common risk factors actually are diseases of the liver or diseases of the bile duct, which some of those are quite rare also. For example, sclerosing cholangitis, which is an inflammatory disorder of the bile ducts, is one of the highest risk factors for this disease. But cirrhosis and hepatitis, hepatitis C, hepatitis B are also common risk factors. Smoking and alcohol have also been associated with increased risk of this disease. Obesity and something called non-alcoholic fatty liver disease has also become clearly a risk factor. And then there are genetic factors as well. The most common genetic syndrome that would be associated with this type of cancer would be Lynch syndrome, which most people would associate with colon cancers, uterine cancer, stomach cancer. But this type of cancer is also a higher risk in that disease. And then diseases like cystic fibrosis, hemochromatosis, which are diseases that can affect the liver, also increase the risk.
So, if we think about people getting these cancers, if let's say they don't have an underlying liver disease that they're aware of, they're a normal human. Maybe they've had some smoking exposure in the past. Maybe they enjoy some alcohol. Maybe they are, like many people in this country today, overweight or even obese. What are kind of the signs and symptoms that might prompt somebody to think, geez, I really need to go to the doctor. This might be a cholangiocarcinoma. I don't know that people would actually have that thought process, but what are the signs and symptoms that might lead to this diagnosis?
Unfortunately, similar to pancreatic cancers, the symptoms can come very late in the disease, leading to this disease being diagnosed at a more advanced stage. The most common presenting scenario would be somebody who has evidence of biliary obstruction, whether that be the bile duct from the gallbladder or the intrahepatic, the bile ducts in the liver. 90% of patients who present with this disease will have some evidence of that. And the symptoms of that are typically things like abdominal pain, particularly in the upper and right upper quadrant of the abdomen, jaundice, which is a yellow color change of the skin, and the whites of the eyes become yellow. Can also be manifested as a dark color in the urine, and then you can see swelling, loss of appetite, swelling of the abdomen, loss of appetite, weight loss. These can be sometimes more insidious symptoms that can go on for weeks or months, before somebody seeks attention for this. So those are the types of symptoms we would be worried about.
Yeah. I think too about people who may have underlying liver disease. Maybe they went to their family doctor for a yearly physical and they did some liver enzyme studies and those were a little bit elevated, and they got an ultrasound and it showed a fatty liver. And if we think about fatty liver or cirrhosis or all of those underlying kind of liver diseases that might predispose to cholangiocarcinoma, what do we know about screening? I mean, when we think about breast cancer, we have pretty good guidelines. Okay, they fluctuate from time to time, but about, the use of mammography in screening for breast cancer. Are there any things like that for patients who may have an underlying liver disease and therefore be at higher risk of cholangiocarcinoma?
For cholangiocarcinoma, there's no proven effective screening test, unfortunately, and that's even true for patients who are at the highest risk, like you're saying, those who we know have liver disease or have one of those rare inflammatory diseases that affect the bile ducts. So the main way that any screening might detect something like this are patients who are being screened who have cirrhosis for hepatomas. So this is a different type of cancer, hepatocellular carcinoma, which is a cancer that arises from the liver cells instead of this type of cancer, cholangiocarcinoma, which arises from the bile duct cells. So sometimes patients are being screened because of their cirrhosis, and we're able to detect this. But otherwise, there's really no effective screening test that we know of yet.
And so that might lead us to have, as you said, a later diagnosis, a later stage at presentation, because patients more likely than not would present when they're symptomatic. Is that right?
Correct. And usually it's somewhat a matter of luck of the draw in terms of where this cancer might develop. Patients who develop this cancer in the more distal bile ducts, so the bile ducts that are already coming out of the liver and the gallbladder, may develop those obstruction symptoms very early, even when they have a tiny lesion that's only a few millimeters in size that can be effectively removed surgically. Unfortunately, sometimes if this disease presents more as arising from the small bile ducts up in the liver, it can become pretty advanced before any of these symptoms actually manifest themselves.
So let's walk through the patient's journey. So supposing somebody has noticed that, their eyes are getting a little yellow, their urine's getting a little dark, despite the fact that they are trying to drink water, they've had some, vague abdominal discomfort. They go in to see their family doctor. That would likely be, I would think, the first step. What happens next?
So the doctor would almost certainly order some laboratory testing with those kind of symptoms to identify if there is abnormalities in the liver function tests, the liver enzymes, or bilirubin, which is the chemical that's secreted, through the bile from the gallbladder and the liver, and if that pathway is obstructed, that level will build up in the bloodstream, and you can detect that, and that's also how it causes the urine to become dark, because the bilirubin starts spilling out of the urine. So we would probably start there. And then if there is something abnormal, getting some sort of imaging to look at the bile ducts, gallbladder, and liver. Most commonly, I would say ultrasound is the first test. It's a quick, easy test and is very effective at identifying problems. But the patient may need further advanced imaging depending on what's seen in that initial testing.
Okay, so let's suppose the patient goes down that path. They get an ultrasound. It looks like some of the bile ducts are blocked. What kind of advanced imaging might they get next, and how is this diagnosis actually made? So often on this show we talk about biopsy and tissue being the issue, and so how does that happen?
So typically next, a CAT scan or even potentially an MRI would be done. There is a type of MRI called an MRCP, which actually is protocol to get more detailed pictures of the bile ducts and the anatomy there. But again, these are just images that might suggest that there is a lesion, a nodule, a mass, whatever it might see. The way to really evaluate it more thoroughly and to obtain tissue of this might be through an endoscopic procedure, like something called an ERCP, where they would pass a camera through the stomach into the small intestine and then up into the small bile ducts, and they can identify strictures, lesions there, biopsy them, and they can also intervene, which is important because if somebody's suffering with symptoms of obstruction there, these lesions can be opened up and stented to relieve that obstruction and relieve the inflammation and injury that's happening to the liver as a result of that. So we get both a diagnosis and there's the first step in the treatment actually starts at that time.
And so, when we think about after the diagnosis is made, when we think about the fact that many of these present late, can you talk a little bit more about the staging studies that might be required? I mean, do we do kind of head-to-toe CT scans to look for distant metastatic spread at that point, or how does that work?
Yes. So CT imaging of the chest, abdomen, and pelvis is the primary staging modality, and that's how we use to calculate the stage and determine what the next appropriate step in terms of treatment would be.
Okay. Well, terrific. We need to take a quick break for a medical minute, but on the other side of the break, we'll talk more about the treatment of patients with gallbladder and bile duct cancers with my guest, Dr. Justin Persico.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where all patients have access to cutting-edge clinical trials at several convenient locations throughout the region. To learn more, visit smilowcancerhospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths. But when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Justin Persico. We're discussing the care of patients with gallbladder and bile duct cancers in honor of Gallbladder and Bile Duct Cancer Awareness Month. And right before the break, we were talking about the fact that these cancers, well, they tend to be not things that we can screen for, often present with vague symptoms, maybe some abdominal discomfort, some jaundice, and ultimately, because they tend not to be so obvious, present late, and often have staging studies with CT scans of the chest, abdomen, and pelvis. What proportion of patients would you say present with distant metastatic disease, and what proportion of patients present with local disease that's more curable?
I'd have to consult to find the exact numbers for you there, but it is probably somewhere 60-40, 60% of patients presenting with more localized disease, 40% presenting with distant metastatic disease. But within those that category of localized disease, there can be very, very different. As I mentioned, tumors can form in the liver itself, which would be different risks, different strategies than tumors that form in the gallbladder or in the bile ducts, or even at the junction where the bile duct attaches to the small intestine called the ampulla of Vater. So it's really a spectrum of diseases, and the risks of metastases, the risks of having more advanced disease would depend on where the lesion started in the first place.
So let's talk a little bit about that. So if we think about, and I know many of our listeners are thinking back to anatomy class, if we think about cancers that arise in the liver itself, in those bile ducts way up inside the liver, arguably it would seem that those are more difficult to access. So can you talk a little bit about what the treatment strategy might be for patients who don't otherwise have disease that has spread outside of the liver, but where their cholangiocarcinoma happens to be inside those intrahepatic ducts?
Yeah, so the mainstay of potentially curative treatment is still surgery. So that is true of whether the tumor is within the liver or outside of the liver. So the first consultation usually that happens is with a surgical oncologist, a hepatobiliary surgeon, to evaluate the liver, look at the patient's existing liver function, if there's any history of liver disease that would preclude being able to do an operation on the liver. But if the mass is potentially resectable, that's always our first choice.
And so potentially patients may have a liver resection for that. In cases where the surgeon says, this is in a location or it is so extensive that we can't resect that portion or that much of the liver. Does that ever occur? And what are patients' options at that point?
That commonly occurs, unfortunately, and within that group of patients, we look at really how extensive, this cancer is. If it's a matter of a limited disease, but just the fact that the patient's liver function or the location or something is precluding a surgical procedure, then other what we call local regional therapies could be considered. These are things like radiofrequency ablation, chemoembolization, radioembolization, all treatments that sort of target that area of the liver involved, and those treatments can be curative. For patients who have multiple lesions in multiple parts of the liver, more advanced, then treating one spot is not going to help when you have other sites of disease that aren't treated. And in that situation is when we discuss systemic therapies. These are chemotherapy, targeted therapies, immunotherapy, depending on the situation.
And is liver transplant ever an option if the disease is localized to the liver, but we just can't resect that portion of the liver?
So it's definitely a hot topic of discussion because in hepatocellular carcinomas, cancers that arise from the liver cells, liver transplantation is one of the mainstays of treatment, one of the potential treatments. But for cholangiocarcinomas, it has not been a routine procedure done, mostly because the prognosis is so much worse for cholangiocarcinoma compared to hepatocellular carcinomas. But there are centers that have utilized that strategy for patients who the only way to surgically resect would be to remove the entire liver. But obviously, that's a much bigger undertaking.
Yeah. And there's no guarantee that we can have a liver donor ready for those patients. If we move to if we move to cholangiocarcinomas that are found in bile ducts outside of the liver, maybe in the gallbladder or the duct that goes from the gallbladder into the small intestine, it would seem to me that those may be more amenable to surgical resection. Is that right?
Generally, yes. Yep, that's my understanding from our surgical colleagues. And sometimes surgery is as simple as cholecystectomy, removing the gallbladder. But usually it's a bit more extensive than a typical cholecystectomy, where they're removing many of the bile ducts, what they can remove, even the portion of the liver where the bile ducts enter the liver. So it might include a small resection of some of the liver as well. And then removal of lymph nodes as well, because lymph nodes are important for us to be able to finalize what our stage would be and assess what the risk of this cancer is after surgery.
Yeah. And so certainly, when we think about having your gallbladder removed, many people think about, small little surgeries, tiny little holes, in and out, day surgeries. I would think that, the type of surgery might really depend on where this cholangiocarcinoma was. If it is, as you said, at that ampulla of Vater, where the bile duct and the pancreatic duct both enter into the small bowel, that might be a little bit more tricky in terms of you might not get it simply by removing the gallbladder. Is that right? What are the options for those patients?
Yeah, because of the anatomy in that area, surgery is more complex, just like you're saying. And this is, well known with pancreatic cancers, especially cancers of the pancreas that are in the head or the first part, the front of the pancreas, where a type of procedure called a Whipple surgery is required to be able to remove those. And that would be the same in this situation, where they'd be operating not only on the tumor itself, but removing part of the small intestine, part of the stomach, part of the pancreas, all as part of that operation.
Yeah, so certainly a big operation. But if the cancer is potentially curative, by being localized, it might still be an option. I want to transition just a little bit to talk about more of the systemic therapies, because as you mentioned, some of these cancers may not be resectable, and some patients, actually about 40%, may present with distant metastatic disease. So can you talk a little bit about the prognosis of those patients? What's their 5-year survival looking like? And what are the options for systemic therapy that are currently on the table?
So this has been a cancer that's been a bit more difficult to study and develop treatments for some of the reasons we've already talked about: the heterogeneity, the different locations, and the different behaviors of the cancer depending on where they might form along the biliary tree, the ducts and the gallbladder. So we can kind of come back to that, but generally because of that, the studies that have been done looking at prognosis and everything are sometimes not entirely accurate. Some of the studies include hepatocellular carcinomas or pancreas cancers or small bowel cancers that develop in that same area as part of these calculations and these numbers. But generally, for patients with with advanced metastatic disease, the estimated survivals are in the 12 to 15 month range, even with current therapies. Because of that poor prognosis, it's really encouraged that kind of the first thing we think about when we see one of these patients is whether there are clinical trials available with newer, potentially better treatments than we currently have. But if that's not something that's available at the time, we do still have several effective systemic therapies for these patients.
Can you talk a little bit more about what those systemic therapies are and what the side effects are? Because, I can imagine that patients who are presenting with, and getting this diagnosis and who are told that, the average life expectancy is 12 to 15 months, maybe thinking, okay, I'm willing to take therapy that will extend that longevity, but not at the risk of being deathly ill for 12 to 15 months. Because if I only have that 12 to 15 months left, I'd rather spend it in as good health and as productively as I can with family and doing all of the things that I want to do before I leave this big blue rock.
Yes. Yeah. So that's always a big conversation that we'll have, and really depends, of course, on the individual patient's medical history, their goals, our discussions with family, these all things. And for patients who want to be as aggressive as possible, it has been shown that combination chemotherapy along with immunotherapy does produce the best survivals in this disease. Also likely has the highest risk of toxicity. But we of course try to manage those toxicities, prevent those toxicities as well as we can to make the treatment tolerable and maintain quality of life, with the goals of improving any potential symptoms that the cancer is already causing, and then of course adding to life, extending life.
Yeah. How effective are they? I mean, in terms of improving that longevity?
So the response rates to this regimen I mentioned, combining chemotherapy and immunotherapy, are somewhere around 40%, which is it's not great. But when it comes to oncology and a lot of the treatments that we use, you're not going to find too much better results in almost any type of cancer. The trick is continuing to keep that response. Most cancers will develop resistance, to their treatment at some point, and this is a type of cancer that seems to develop resistance to treatment, maybe a little faster than other types.
And so, in terms of extending life expectancy, if you did respond to therapy, if you were in that lucky 40%, how much bang can you get out of the buck? How much juice can you squeeze out of that lemon in terms of extending life expectancy?
Yeah. So the real goal here with this initial treatment of chemoimmunotherapy is really to get the immunotherapy to work. That's where the biggest breakthrough in cancer treatments, of the last 20 years has occurred, and in this disease as well, the addition of immunotherapy has clearly helped our traditional chemotherapy treatments. And if that immunotherapy starts to have effects, there are patients who can have very long-term survivals. It's only 10% or so, but those patients can live years with this disease and be actually in remission for that time. So there is a lot of promise still.
Dr. Justin Persico is an assistant professor of medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.